Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and in our next installment of the lung cancer series, we will be getting into some data behind the management of locally advanced non-small cell lung cancer. In our last talk, we really focused on early stage non-small cell lung cancer. And in this talk, we're talking about locally advanced disease. So what makes a patient have locally advanced non-small cell lung cancer? Typically, when we say locally advanced, we're referring to stage 3 disease or higher. So things that automatically make you stage 3 are, number one, if you have any mediastinal nodal involvement. So as soon as there's N2 level nodes, that makes it stage 3. If there is a tumor that's greater than 5 centimeters and there's any type of nodal involvement, so T3N1, or if a tumor is greater than 7 centimeters, or if there's any kind of blunt invasion of other structures such as the chest wall or things like that, that is a T4 tumor, and that is also stage 3. So T1 to 2 N2, T3 N1, and T4 N0. That's typically what we're referring to, that level of disease or higher when we say locally advanced non-small cell lung cancer. So in this talk, the goal is really to talk about the management of locally advanced non-small cell lung cancer. We'll talk about kind of the indications for surgery and which patients may qualify for surgery, but there are some situations where patients with even locally advanced disease go for surgery and they might need postoperative radiation. So we'll talk about the trials that guide our management there. We'll talk about comparing surgery versus chemoradiotherapy, and then we'll really get into kind of the mainstay of management of these locally advanced cancers, which is often chemoradiotherapy followed by maintenance immunotherapy, and we'll talk about some different trials looking at various fractionation regimens as well. The first set of trials that we'll talk about are a couple of studies looking at the role of postoperative radiotherapy, or PORT. So historically, N2 disease, meaning mediastinal lymph node involvement, and positive surgical margins were indications for postoperative radiation. However, 2 modern prospective randomized trials have investigated the role of PORT, and they find that there does not seem to be a benefit to this in the case of N2 disease. The clearest indication for PORT is if there is any residual disease. So if there's an R1 resection, meaning that patients have a positive surgical margin or microscopic residual, or an R2 resection, meaning that there is residual disease left behind and there's a macroscopic residual. Those are really the clearest indications for PORT, R1 or R2 resection. There does not seem to be a benefit to routinely treating with PORT just because patients have N2 disease. So let's take a look at these trials. The Lung-ART study took patients with stage 3A non-small cell lung cancer, so N2 disease, and they randomized them to either receive PORT or no PORT. The group that received postoperative radiation was treated to a dose of 54 gray in 27 to 30 fractions using mostly 3-dimensional planning techniques. The area that was treated included the involved lymph node stations as well as the pleura adjacent to the tumor bed, and they included a 1 centimeter CTV margin. Now, most of the patients did get chemotherapy as well. They received either adjuvant or neoadjuvant chemotherapy, but the randomization was radiation or no radiation. So around 2/3 of patients had 1 lymph node station involved, 1/3 had more than 1 station involved, and around 80% of patients had a lobectomy, and around 30% of patients had an R1 resection, meaning they actually had a positive surgical margin. There was less than 1% R2 resection. So most of the patients had a negative margin, and they were included just by virtue of that N2 disease, but 30% of the patients in this study did have a positive surgical margin. The results showed no significant difference in disease-free survival or overall survival with the use of postoperative radiation. So the 3-year disease-free survival was 47% versus 44%, not statistically significant. And the 3-year overall survival was just around 67 to 69% in both groups. So no improvement in outcomes with the addition of postoperative radiotherapy. The group that received postoperative radiation did have less mediastinal recurrences. So the rate of mediastinal recurrence was 25% in the radiation arm versus 46% in the no radiation arm. But they did see higher levels of grade 3 to 4 pneumonitis with port. So 6% with radiation compared to less than 1% without the radiation. So there are some criticisms of the LungArt trial. One of them is that the trial may have been underpowered to detect a disease-free survival or overall survival benefit. The radiation seems to have increased toxicity, and in the modern era, we would not be utilizing 3D radiation. We would be using IMRT. Only 11% of patients in this trial received IMRT, and so maybe we should study this again, this time mandating that IMRT is used. And it's possible that radiation may also show a greater benefit as the nodal burden increases. And in this trial, about 2/3 of the patients, so the majority, only had one lymph node station involved. Regardless, this is the evidence that we have, and the LungArt trial, understanding how it was designed, it did not show any benefit for routine radiotherapy for N2 disease. The other key trial that evaluated the role of postoperative radiotherapy is the PORT-C trial. So just like LungArt, PORT-C took patients with pathologic N2 disease, so stage 3A non-small cell lung cancer, who had resection followed by 4 cycles of chemotherapy, and they were randomized to port versus no port. The dose for port was 50 gray in 25 fractions, and in this trial, almost 90% of patients were treated with IMRT. The criticism of this trial is that there was poor protocol adherence, so around 24% of patients in the radiation arm actually did not have any treatment. The intention to treat analysis showed no improvement in disease-free survival or overall survival with port, just like LungArt. And just like LungArt, the local regional recurrence-free survival was improved. So the 3-year disease-free survival was 41% versus 33%, and that was not significant. The 3-year overall survival was around 80% in both groups. The 3-year local recurrence-free survival was 67% with port versus 60% without, and that did reach significance. So there's a 7% improvement. And then they also performed a per protocol analysis just because, a quarter of patients in the radiation arm didn't actually undergo radiation treatment. And there was a disease-free survival benefit on the per protocol analysis, not an overall survival, but they did see a disease-free survival benefit. But again, you have to take the per protocol analysis with a grain of salt because there's probably a reason that the patients that were treated. They probably had kind of better prognostic factors to begin with. So this is important. PORT-C was a study from China. LungArt was a study from Europe. But this was another example of a trial with port versus no port for N2 disease, and there was no benefit to the port in the setting of N2 disease. So the big takeaway here regarding the role of postoperative radiotherapy in locally advanced non-small cell lung cancer is that the clearest indications for postoperative radiotherapy are R1 or R2 resection. So R1 refers to a positive surgical margin, meaning there's microscopic residual, and R2 refers to gross residual or macroscopic residual disease. So R1 or R2 are the strongest indications for port. And if indicated, we typically offer postoperative radiation after the completion of adjuvant chemotherapy. So these patients will typically complete 4 cycles of chemotherapy, and then we will treat them with port. Now, we strongly prefer concurrent chemoradiotherapy, especially if there's, gross residual disease. But a sequential approach may be reserved for patients that are more frail if we're afraid that they won't be able to tolerate the concurrent chemoradiation. So R1 or R2 resection are your clearest indications for port. Historically, we know that port was performed for N2 disease, but in the setting of the modern trials that we have, the LungArt as well as PORT-C trials, postoperative radiation is not routinely indicated for pathologic N1 or N2 disease. If patients do have pathologic N2 disease, we might consider port if there are particular risk factors. For example, if they have extracapsular extension, multi-station involvement, an inadequate lymph node dissection or sampling. Remember, they need to have at least one hilar region and three mediastinal sampled whenever they're taken for surgery. Or if they are refusing or not able to tolerate adjuvant chemotherapy. So those are some indications that we might consider port. But, the textbook answer is if it's just N2 disease, we typically do not routinely offer postoperative radiation. And when we are offering postoperative radiation, I think it's important to realize that this is not an ideal scenario, right? Because these patients are already going to be getting surgery and they're probably going to be getting adjuvant, or maybe they got neoadjuvant chemotherapy and probably immunotherapy. So at that point, if we're giving postoperative radiation, it's really trimodality because they're getting surgery, systemic therapy, as well as radiation. And we're going to talk about the studies here in a minute, but as you will see, there's really no benefit to trimodality for these patients. And so if we take them for surgery and are not able to get a clean margin, we end up subjecting them to a whole lot of therapy. And, there is a perfectly good non-operative approach, which is chemoradiotherapy followed by maintenance immunotherapy. And that can avoid surgery and the morbidities associated with that entirely for these patients. So, it's challenging to evaluate these patients and select kind of the appropriate treatment modality. But I think it's really important for us to be cognizant of this fact that, if we are in a situation where we have to offer postoperative radiation, that probably means that they had a surgery with a positive margin at the very least. And if that's the case, that's something that we want to try to think about up front and try to avoid that scenario if possible. If our surgeons are concerned about having a positive margin at the time of surgery, then a better option might just be to kind of not pursue the surgery route and just treat with definitive chemoradiotherapy followed by maintenance immunotherapy. So we really try, and this is why it's important for us to be vocal in tumor boards and things like that. We try to spare our patients from the toxicity and the morbidity of trimodality. And we really don't want to subject patients to any kind of unnecessary treatment. This brings us to the data that I was alluding to, comparing surgery versus chemoradiotherapy. I think that this data is far from perfect, but it suggests that there's no overall survival benefit to trimodality. And so therefore, our preferred approach is either to pursue surgery or radiotherapy. We try to stay away from pursuing surgery with the knowledge that patients might need postoperative radiotherapy, because the rationale is, well, if they're going to be getting a surgery and then requiring postoperative radiation anyway, we might as well treat them with chemoradiotherapy, and that may be better tolerated. EORTC 08941 was a randomized trial of patients with stage 3A N2 non-small cell lung cancer, and they were treated with induction platinum-based chemotherapy for 3 cycles. And if they had a good response to the chemotherapy, they were then randomized after induction chemo to either surgery or radiation to a dose of 60 to 62.5 gray. 40% of patients in the surgery arm actually ended up receiving postoperative radiotherapy, and the trial showed no significant difference in the median overall survival or the progression-free survival with surgery versus radiation. So the 5-year overall survival was right around 15% in both arms, not statistically different. And the 2-year progression-free survival was right around 25% in both arms. Again, no significant difference between surgery or radiation. So the EORTC 08941 trial suggested that surgery does not seem to improve outcomes compared to chemoradiotherapy alone. The intergroup 0139 study, also called the Albane study for the first author, is kind of an infamous study also looking at chemoradiotherapy with or without surgery. So this time, as opposed to the EORTC trial where they were looking at induction chemo followed by either surgery or radiation, all of the patients in this trial had concurrent chemoradiotherapy, and then they were randomized to surgery or no surgery. So they took patients with stage 3 non-small cell lung cancer, N2, and these patients either received 45 gray of radiotherapy with concurrent cisplatin and etoposide for 2 cycles, and after 45 gray, they received surgery. Or they were taken to a full definitive dose with 61 gray of radiotherapy, and they received concurrent cisplatin and etoposide for 4 cycles. So chemoradiotherapy plus or minus surgery. The results of this trial showed that the progression-free survival significantly improved with surgery, but this did not translate to a difference in overall survival. So the 5-year progression-free survival was 22% with surgery compared to 11% with just chemoradiation and no surgery. And that was statistically significant. So the PFS sort of doubled at 5 years, from 11% up to 22% with the addition of surgery. However, the 5-year overall survival was not significantly different. It was 27% with surgery versus 20% with chemoradiation. More of the patients in the chemoradiation arm had local progression, and more patients died without progression in the surgery arm. So it kind of balanced itself out. Basically, the chemoradiation had more local progression, but the patients that had surgery died of other causes that were not related to progression. There was an exploratory analysis of this study that showed an improved overall survival, specifically in the lobectomy patients compared to chemoradiotherapy, but not with pneumonectomy. So in the lobectomy subgroup, the overall survival was 36% compared to 18% in the patients that received definitive chemoradiotherapy, and that was statistically significant. But again, this was an exploratory analysis, and the trial probably was not powered for that comparison. So the big takeaway from this intergroup study is that there's no overall survival benefit to chemoradiotherapy versus chemoradiotherapy followed by surgery. So adding that surgery doesn't seem to provide an overall survival benefit, unless possibly a lobectomy is performed based on that exploratory subgroup analysis that we talked about. Many prefer in practice chemoradiotherapy alone over the induction approach, unless a patient is extremely, extremely healthy and would tolerate trimodality and would ultimately tolerate a lobectomy. And so this intergroup trial is often referenced, so very important to know. The ESPATU trial asked a very similar question to the intergroup trial. They took patients with stage 3A and select 3B patients with non-small cell lung cancer and randomized them to get induction chemoradiotherapy to a dose of 45 gray in 30 fractions BID. And they were subsequently randomized to either definitive chemoradiation, so they got a boost up to 65 to 71 gray, or surgery after that induction chemoradiation. So just like the Albane trial, they all got chemoradiation up front, and then some of them got more chemoradiation, some of them went on to get surgery. Unfortunately, the trial was slow to accrue and actually closed early. They closed after recruiting 246 out of 500 planned patients, so it was kind of underpowered. And then furthermore, after the induction chemotherapy and radiation, only 65% of patients went on to actually get randomized. So the trial was fairly underpowered. That said, they found no significant difference in overall survival or progression-free survival between the two arms. So the overall survival was very similar, 44 versus 40%, not significant. The progression-free survival was 32 versus 35%, also not significant. And they found no significant differences in the quality of life. So ESPATU is another important trial to know, looking at chemoradiation plus surgery versus definitive chemoradiation alone. And while it was underpowered to meet its endpoints, they found no significant difference in the overall survival or the progression-free survival between the two arms. So what are the big takeaways here? Because I think that these trials can be a little bit difficult to digest. So the first thing that I'll start by saying is that the patients that were included in the intergroup trial and the ESPATU trial were technically considered resectable patients. Now, in a tumor board setting, you may find that the criteria for who is considered resectable, or the criteria for surgical operability, they can sometimes be a little bit unclear, and they can also be controversial. Relative contraindications to surgery, so I think kind of the textbook contraindications that we think about to surgery are things like bulky N2 disease, so nodal disease that's greater than 3 centimeters, multi-station N2 disease, so involving more than one lymph node level, or N3 disease as well. And those are kind of considered the textbook criteria, I would say, for inoperability, so surgically inoperable. And the reason that these patients are considered surgically inoperable can be a combination of, number one, poor prognosis in these patients, and number two, the technical feasibility for the surgeon. And the technical feasibility does vary a lot based on the surgeon that you're talking to, as well as the institutional practice. And therefore, these criteria are controversial because a surgeon at one institution may think that a patient is technically feasible to undergo surgery and they might consider them operable, whereas another surgeon at a different institution may disagree. And so there is a lot of controversy there as to who is technically an operable patient. So you should know that those are kind of the relative contraindications: bulky N2, multi-station N2, or N3 disease. There's also no evidence based on the trials that we talked about that chemotherapy plus surgery is better than chemoradiation for stage 3 non-small cell lung cancer. They seem to be, equivalent modalities. It's unclear if chemoradiation followed by surgery, so trimodality, improves PFS or OS for these patients. I think mostly the evidence suggests that no, it really doesn't. The intergroup trial was negative for overall survival benefit across the cohorts, although they did have a progression-free survival benefit. The ESPATU trial, with that caveat that it was underpowered, was negative for a difference in both overall survival and progression-free survival. The intergroup trial, when they looked at that subgroup of patients that received lobectomy, it did seem to show an improved overall survival in those patients on post-hoc analysis. But again, these trials are muddy. They're not completely clear, and it's difficult to interpret. So I would say that for most patients, the approach is to pursue either surgery or chemoradiation with maintenance immunotherapy, but typically not both. I personally have not seen any patients treated with trimodality with like run-of-the-mill non-small cell, stage 3 non-small cell lung cancers, but this may be institution dependent. What I would say for patients that are going to get surgery after chemoradiation, these patients need to be very, very carefully selected. So they need to have excellent performance status. The mediastinum should be restaged to ensure that it is, surgically operable. And they should be planned for a lobectomy, as we know that pneumonectomy, the results are worse and the survival is worse for patients that undergo a pneumonectomy. The other huge caveat to the trials that we talked about, including the intergroup trial, the ESPATU trial, they were all performed in a pre-immunotherapy era. In the modern era with neoadjuvant chemoimmunotherapy, a lot of these patients, even with stage 3A disease, for example, will be undergoing neoadjuvant chemoimmunotherapy before they are taken for surgery. And this is another place where we need to be very, very cautious, especially in these tumor board discussions, because there is a danger of using neoadjuvant chemoimmunotherapy to try and, convert a patient that's not surgically operable to surgically operable. And it's really, really important for us to understand that the neoadjuvant immunotherapy trials did not include patients that were unresectable up front. And so the goal of neoadjuvant immunotherapy is really not to convert patients that were unresectable to resectable with this approach. So again, this is an area that can generate a lot of controversy in tumor board discussions. And so it's really important for us to be very familiar with the data, so that we can kind of advocate for our patients and make sure that we are not pursuing treatments that might kind of increase their morbidity, especially trimodality. It's very difficult for patients to tolerate chemotherapy and radiation and surgery, and so we try not to pursue more than they can tolerate. So what I would say the big takeaway is that based on the data that I've presented, for most patients, we try to decide up front if they are resectable or if they are not resectable. And our approach is to, depending on which category they fall in, and also depending on their medical operability. So are they medically candidates for surgery? We either try to pursue surgery, and if we're pursuing surgery, then we can combine that with, most of the times in the modern era, it's going to be neoadjuvant chemoimmunotherapy, and they may get adjuvant immunotherapy on the back end. So surgery plus systemic therapy or definitive chemoradiotherapy. But we typically try not to combine both. The notable exception to this rule is superior sulcus tumors. Superior sulcus tumors are treated along a little bit of a different paradigm, which I'm going to talk about in this next trial. SWOG 9416 is the seminal trial that established the treatment paradigm for superior sulcus tumors, which is chemoradiation followed by surgery whenever possible. So the reason that superior sulcus tumors kind of fall under a different treatment paradigm is because historically, the outcomes for these tumors were very poor, and these tumors were difficult to manage just because of a very challenging anatomic location. They can often present with Pancoast syndrome. They're also called Pancoast tumors, the superior sulcus tumors. And Pancoast syndrome, if you recall from medical school, is that triad of arm and shoulder pain, Horner's syndrome, and hand muscle atrophy. And so, the reason for those symptoms is because these tumors can be invasive and they can involve structures such as the brachial plexus, leading to plexopathies and things like that. So the SWOG trial ran in the late 90s, and it took patients with solitary T3 to T4 N0 to 1 superior sulcus tumors, so non-small cell lung cancer histologically, and they either had to have Pancoast syndrome or CT or MRI proven invasion of critical structures, so either the chest wall, the spine, or subclavian vessels. And these patients were treated with induction chemotherapy for 2 cycles, cisplatin and etoposide, and then radiation to a dose of 45 gray and 25 fractions. And they subsequently underwent thoracotomy and resection in 3 to 5 weeks. And then after surgery, they received 2 additional cycles of chemotherapy. So induction chemoradiation to a dose of 45 gray, then surgery, and then 2 more cycles of chemotherapy on the back end. 80% of the patients that were enrolled in this trial ended up going for surgery, and 94% of these patients were able to achieve an R0 resection, which is much higher than historical standards in this patient population. Historically, in this study, I believe they quoted around a 60% complete resection rate, whereas with the upfront chemoradiation, they achieved 94% R0 resection rate. 55% had a pathologic complete response. So excellent outcomes with this approach. The median survival was 33 months for all the eligible patients, and it was actually 94 months for the patients that actually underwent an R0 resection. So if you undergo an R0 resection, it makes sense. Survival is expected to be longer. The 5-year overall survival was 54% after a complete resection versus 44% for all patients. And these patients also had an improved response if they had a pathologic complete response. So the SWOG 9416 trial showed excellent outcomes with induction chemoradiation followed by surgery, followed by chemotherapy for these superior sulcus tumors. And that really established the standard paradigm for these superior sulcus tumors. So just to summarize, the general paradigm for superior sulcus tumors is induction chemoradiotherapy followed by surgery, and that induction chemoradiation dose is a little bit lower than what we would go to for our definitive dose for treating non-small cell lung cancer. So a definitive dose is 60 gray. For the induction chemoradiation, we might just treat to 45 to 50 gray using conventionally fractionated radiation. Now, if we don't think that the patient is going to be a good candidate for surgery, for example, if they have a T4 superior sulcus tumor and then high nodal burden, N2 disease, things like that, we know that they're not going to get surgery, then we can always treat with our, go-to definitive dose for stage 3 non-small cell lung cancer, which is 60 gray in 30 fractions. If you talk to experienced practitioners, a lot of them will also tell you that Sometimes, even if the plan is for surgery and even if it seems like the patient is going to be surgically operable, things can happen, the patient can deteriorate. After chemoradiation, the surgeon might look at the patient and say, I don't think they're a good candidate for surgery, and they might not always go for surgery. And if that happens and we've stopped after a non-definitive dose of 45 to 50 gray, if there's a treatment break, then we know that the radiation doesn't work as well. And so a lot of experienced practitioners will say that what they try to do is give 60 gray as a definitive dose whenever possible. And depending on the institution and depending on how comfortable the surgeons are with operating after the patients have received 60 gray, sometimes they can get away with that and just give the definitive dose, because we can't always predict if these patients are truly going to be taken for surgery or not. And then the other point I'll make is that, there's not good data for superior sulcus tumors in terms of immunotherapy, but some people will extrapolate from other data and utilize immunotherapy and targeted therapy in the adjuvant setting. This brings us to our next set of studies that look at systemic therapy along with chemoradiation. So we'll start by talking about some of the historical studies that established chemoradiotherapy as the standard. And then the Pacific trial was published, which showed that adjuvant durvalumab, so maintenance durvalumab after completing chemoradiotherapy, improved survival. And that is really the standard of care, for all patients, regardless of their PD-L1 status. We think about chemoradiation followed by maintenance durvalumab as the standard of care. So far, the only exception to this is for patients that have an EGFR mutation. If they have the appropriate EGFR mutation, then we think about chemoradiation followed by osimertinib, which is a third-generation tyrosine kinase inhibitor that specifically targets the EGFR. So for EGFR mutation, as long as it's the appropriate mutation, chemoradiation followed by osimertinib, but for everyone else, it's chemoradiation followed by durvalumab. So very briefly, here are some of the historical trials that established chemoradiation as sort of the standard of care. So the CALGB 8433 trial looked at induction chemotherapy followed by radiation versus radiation alone and found that induction chemotherapy improves overall survival. And that makes sense because these patients with non-small cell lung cancer, especially locally advanced non-small cell lung cancer, have a very high chance of distant metastasis. So if we add systemic therapy, we're going to help them live longer. So CALGB 8433, induction chemo followed by radiation improves survival. RTOG 9410 established concurrent chemoradiation as the standard of care and found that the concurrent approach provided around a 5% benefit in overall survival compared to a sequential chemo followed by radiation approach. So based on RTOG 9410, we started doing concurrent chemoradiotherapy. And then there was CALGB 39801, which looked at induction chemotherapy followed by chemoradiation, and they found that there was actually no benefit to induction chemotherapy before chemoradiation. So, we start off with upfront chemoradiation when we're treating definitively with radiation. And in terms of which concurrent chemotherapy is used, cisplatin etoposide has been used in a lot of the trials that we talked about, but carboplatin and paclitaxel were actually very commonly used as well. And that is actually the regimen that I have seen used most often, which is carboplatin and paclitaxel. There was a Chinese randomized trial that compared the two regimens, so cisplatin etoposide versus carboplatin paclitaxel, and they found no significant difference in toxicity. So the cisplatin etoposide tended to cause higher grade 3 or worse esophagitis. The carboplatin paclitaxel tended to cause higher grade 2 or worse pneumonitis. I think from what I have heard from the medical oncologists, it seems like carboplatin paclitaxel is often preferred just from a toxicity profile. And so this is the regimen that I have seen used most often for non-small cell lung cancer. So based on those aforementioned trials, chemoradiotherapy with concurrent chemotherapy and radiation was a standard of care for a long, long time until the Pacific trial was published, which looked at chemoradiation followed by maintenance durvalumab. The Pacific trial took patients with stage 3 unresectable non-small cell lung cancer who had undergone platinum-based chemoradiation to a dose of 54 to 66 gray, and they randomized them 2-to-1 to either adjuvant durvalumab, 10 milligrams per kilogram IV given every 2 weeks for 1 year, versus placebo every 2 weeks for 1 year. And the adjuvant 1 year of durvalumab provided a significant improvement in overall survival as well as progression-free survival. So the median progression-free survival went from 6 months with chemoradiation alone up to 17 months with the durvalumab. The 18-month progression-free survival was 27% versus 44% with the durvalumab, so huge improvement in the PFS. The 2-year overall survival had a 10% improvement, so the 2-year overall survival went from 56% without up to 66% with the durvalumab, so 10% improvement in overall survival. And these rates of overall survival were kind of never before seen, so this was very exciting. The 5-year overall survival was 43%, which was again 10% higher than 33%, which was seen without the durvalumab, and that had kind of been the historical standard. So 10% improvement in overall survival with the durvalumab. The progression-free survival, almost doubled. So very, very significant improvement with the adjuvant durvalumab. They did see higher pneumonitis rates in the durvalumab group, but a 10% improvement in overall survival for non-small cell lung cancer that's locally advanced is huge. And so this was a practice-changing trial. So adjuvant durvalumab is now standard of care for locally advanced non-small cell lung cancer, and that holds true regardless of the PD-L1 status. There was a post-hoc analysis of EGFR mutant patients from the Pacific trial that actually suggested no benefit to durvalumab compared to the placebo, specifically in the EGFR mutant patients. And so that leads us, it kind of provides us a segue into the next trial that we'll talk about, which is the LAURA trial. The LAURA trial was a phase 3 double-blinded randomized controlled trial of patients with unresectable stage 3 non-small cell lung cancer, specifically with EGFR mutations that are compatible with the tyrosine kinase inhibitors that we have. So exon 19 deletion or exon 21 L858R mutation. There is another exon 20 mutation that exists for EGFR, but we can't use the osimertinib for exon 20 mutations. It's only if they have exon 19 deletion or exon 21 L858R mutation. So if they had the appropriate EGFR mutation, patients were randomized 2-to-1 to either chemoradiation followed by osimertinib or chemoradiation followed by placebo. And they were continued on the osimertinib or the placebo until they had progression. The results showed significantly improvement progression-free survival with the osimertinib. So the median progression-free survival was 39 months with the osimertinib versus just 6 months with the placebo. And the 1-year progression-free survival rate was 74% with osimertinib versus 22% with placebo. So it did amazing, right? The median progression-free survival went from 6 months to almost 40 months, and the 1-year progression-free survival went from barely 25% up to 75%. So huge improvement with the osimertinib. So far, the LAURA trial has only shown a progression-free survival benefit. It was published fairly recently. So adjuvant osimertinib is used for these EGFR mutant patients. However, we're still waiting for those overall survival results. The last trial that I'll mention in the context of systemic therapy for locally advanced non-small cell lung cancer is the PACIFIC-2 trial, which looked at chemoradiation with concurrent and adjuvant durvalumab. So remember, PACIFIC looked at just adjuvant durvalumab after chemoradiation was complete, so maintenance durvalumab for 1 year, and they found a significant PFS and OS benefit to that regimen. Pacific 2 was asking, should we be adding durvalumab concurrently as well? So they randomized patients to chemoradiation with concurrent and adjuvant durvalumab versus concurrent and adjuvant placebo. And this was actually a negative trial, so there was no PFS or OS benefit if you look at those Kaplan-Meier curves to the addition of durvalumab concurrently as well as adjuvantly. And so as per the Pacific trial, chemoradiation followed by adjuvant durvalumab really remains the standard of care. The big takeaway here is that the Pacific regimen is really the standard of care for patients that are not candidates for surgery. So we treat them with concurrent chemoradiation using a platinum-based doublet. Oftentimes it's something like carboplatin plus paclitaxel. And then the radiation dose is 60 gray in 30 fractions to the primary tumor as well as the involved nodes. There's retrospective data that suggests there's no benefit to elective nodal radiation in lung cancer, and in fact, it can just increase toxicity. So we don't treat elective nodes, we just treat the primary tumor and involved nodes to 60 gray in 30 fractions. And then after they receive the concurrent chemoradiation, they go on to receive maintenance durvalumab every 4 weeks for 1 year. If patients have an EGFR mutation, and it has to be the appropriate EGFR mutation, so exon 19 or that L858R mutation, then they can receive concurrent chemoradiation followed by maintenance osimertinib. As I just mentioned, the current standard dose in terms of radiation for locally advanced non-small cell lung cancer is 60 gray in 30 fractions. And that's based on an old RTOG trial where they compared different dose levels, 40, 50 versus 60 gray. Some folks will boost in some cases up to 66 gray, but the general standard is generally accepted as 60 gray in 30 fractions, so 2 gray per fraction. There were some trials looking at dose escalation, and the most infamous trial was RTOG 0617, which we'll talk about in a minute, compared 60 gray versus 74 gray. And unfortunately, in this setting, dose escalation does not seem to help. And in RTOG 0617, 74 gray actually led to worse outcomes compared to 60 gray. So the standard is 60 gray in 30 fractions. In some cases, folks might boost up to 66 gray. And let's talk about some of the trials looking at dose escalation that were negative. RTOG 0617 had a 2x2 randomization design, and they were actually asking 2 questions. So one randomization was based on dose level, and they randomized patients to 60 gray in 30 fractions versus 74 gray in 37 fractions. The other randomization tested chemoradiation alone, which was the standard of care at that time, versus chemoradiation with concurrent and adjuvant cetuximab. It turned out that cetuximab provided no benefit and worsened toxicity, so it was negative for that question. And it was also negative for the dose escalation question. And in fact, dose escalation, very interestingly, led to worse overall survival. So the median overall survival was 29 months in the 60 gray arm versus 20 months in the 74 gray arm, and that was statistically significant. The 5-year overall survival was 32% versus 23%. So a 10% detriment in the 5-year overall survival, which is very interesting. The local control was not better with dose escalation. So the 5-year local failure rate was 38% versus 46%, not significantly different. And the 5-year progression-free survival was 18% versus 13%, not significantly different. So there's many theories about why dose escalation didn't work, and everyone was pretty baffled by this when this trial first came out. There's many theories about this. Some propose that maybe there's a better immune response at 60 gray. Maybe there were some variations in terms of contouring and the quality analysis of the radiation plans. The most robust explanation, I think, which is now the widely accepted explanation based on post-hoc analyses of this trial, is that there was greater cardiac toxicity with higher doses, and that contributed to mortality. So this is really thought to be related to specific substructures of the heart that should be avoided. But the big takeaway here is RTOG 0617 was a negative trial. There was no benefit to cetuximab, nor was there a benefit to dose escalation. And in fact, dose escalation was harmful with a detriment in overall survival. They say that when life gives you lemons, you make lemonade. And so after this lemon of a trial, RTOG 0617, there were actually quite a few secondary analyses that gave us a little bit more insight as to why, explaining why we saw negative outcomes with this study, and also kind of giving us some useful dose constraints that can guide our management of locally advanced non-small cell lung cancer. So there was an unplanned secondary analysis that was published in 2017 comparing 3D versus IMRT because there was a mixture of techniques used in RTOG 0617. And this analysis found that there were higher rates of grade 3 or worse pneumonitis with 3D versus IMRT, which makes sense, right? The grade 3 or worse pneumonitis was 20% with 3D versus 8% with IMRT. So more than half, it was more than halved with the use of IMRT, basically. And the lung V20 dose was correlated with the rate of grade 3 or worse pneumonitis on multivariate analysis. So a standard lung constraint that we typically use for planning lung cancer is V20 gray, less than 35%. And this was correlated with the rate of grade 3 or worse pneumonitis. The lung V5 was not correlated. They also saw that there were higher doses to the heart with 3D versus IMRT. And the heart V40 dose correlated significantly with overall survival on multivariate analysis. So another constraint that folks will often use is keeping the heart V40 gray less than 20%. There's an additional dose for the heart V50 less than 25% that comes from a single institutional analysis out of WashU for patients that were treated based on RTOG 0617 guidelines. And that comes from that analysis. So I think V40 less than 20 is what I have seen, that we try to use just because it's a more stringent constraint, harder to meet. The esophagus constraints that I have listed on this slide are mean less than 34 gray and V60 less than 17%. These doses come from Quantec, the mean dose at least, and then the V60 less than 17% comes from a meta-analysis that was published a while ago, more than 10 years ago. And more recently, there's actually been data in the esophagus kind of organ at risk space to try for contralateral esophageal sparing. So we actually draw out the esophagus that's on the opposite side of the PTV volume and try to spare that volume. So there's a couple of studies looking at the benefit of that. So RTOG 0617 was a negative trial for dose escalation, but a lot of the patients on that trial were treated with 3D planning, and we now know that they probably had higher heart doses, which contributed to their increased mortality in the dose escalation arm. There's a more modern trial, RTOG 1106, which was published very, very recently, and this is a phase 2 trial of PET-guided dose escalation. So after 4 weeks of chemoradiation, so after 20 fractions, all patients underwent a new PET-CT, so a restaging PET-CT at 4 weeks. The standard arm went up to 60 gray and 30 fractions regardless of the PET response, so they still got, 2 more weeks of radiation. In the experimental arm, they created a kind of PET adaptive plan based on the PET response. So if whatever disease was residually lighting up on the PET scan was boosted to a dose of 80.4 gray. And when they planned it, they made sure that the mean lung dose did not exceed 20 gray. And so the median radiation dose that was actually delivered in the adaptive arm was 71 gray, but they allowed for a total of up to 80.4 gray. So essentially boosting what was still residual on that 4-week PET-CT. They found no significant difference in grade 3 or worse toxicity. There was slightly more grade 2 or worse esophagitis in the adaptive arm, 43% versus 31%, but no significant difference in grade 3 toxicity or worse, which is a win. But they also saw that there was no significant difference in local control between arms. So the 2-year freedom from local progression was 59% in the standard arm versus 55% in the adaptive arm, not significantly different. So we again have another trial showing no benefit in local control to dose escalation. which is a little bit baffling if you think about it, because you would expect that a higher dose leads to better local control, but for whatever reason, in lung cancer, that does not seem to be the case. There's an ongoing study, NRG-LU008, which is looking at trying to give a higher dose to the primary using SBRT. So the experimental arm in this trial is getting SBRT to the primary with a BED of at least 100 gray, followed by 60 gray in 30 fractions chemoradiation to the mediastinum, and then maintenance immunotherapy. The standard arm is just getting 60 gray and 30 fractions to the primary plus mediastinum, followed by maintenance immunotherapy. So it'll be interesting to see if giving a higher BED to the primary would help with better local control and better outcomes. The bottom line is, so far, there has not been any studies showing a benefit to dose escalation. And so, like I said, 60 gray and 30 fractions is really the standard of care. Let's end here by talking about a trial looking at accelerated hypofractionation in 15 fractions for patients with poor performance status. This is a phase 3 randomized trial from UT Southwestern that took patients with stage 2 or 3 non-small cell lung cancer that had poor performance status. So they had to have either an ECOG performance status of 2 or worse, more than 10% weight loss in the last 6 months, or they were just patients that were deemed ineligible for concurrent chemotherapy. And they were randomized to 60 gray and 30 fractions conventional radiation versus 60 gray and 15 fractions with accelerated hypofractionation. So 60 gray, but this time in 15 fractions instead of 30 fractions. This was designed as a superiority study, so it was not powered for determining non-inferiority or equivalence, and it actually did not complete the targeted accrual of 226 patients due to futility. They only reached 103 patients. But the results showed that accelerated hypofractionation was not superior to conventional fractionation. So the median overall survival was 38% with 15 fractions versus 45% with 30 fractions, not significantly different. The median overall survival was 8 months versus 10.5 months, and the progression-free survival median was 6.5 versus 7.5 months. The grade 2 esophagitis was higher with the hypofractionation, but it did not reach statistical significance, possibly because it was a smaller sample size, but 22% with 15 fractions versus 9% with 30 fractions. So the takeaway from this trial is that 60 gray and 15 fractions was not superior to 60 and 30 fractions, and the trial was not powered to determine non-inferiority or equivalence. So all we can say is that it was not superior. That said, 60 gray and 15 fractions may be an option for patients that have very poor performance status who aren't going to be able to tolerate concurrent chemoradiation. And this is a regimen that I have seen used in that setting. So, a summary of our trials talking about radiation dose. As we discussed, dose escalation in locally advanced non-small cell lung cancer has not shown any benefit. And it did not show a benefit in RTOG-0617, which used more 3D planning, but even in an era of kind of that PET-guided dose escalation with the more modern RTOG trial, even though the toxicity was the same, we still saw that there was no local control benefit with PET-guided dose escalation. So the standard dose for non-small cell lung cancer is 60 gray and 30 fractions. In older trials, they did not use heterogeneity corrections, and the lung was really assumed to be the same density as water. But actually, the dose ended up being higher because lung is not water, it's air. And so in those older trials, the argument is that, well, actually a 10% higher dose was given and 66 gray was achieved. So some folks may still try for 60 up to 66 gray, but really the standard dose is 60 gray and 30 fractions. RTOG-0617, like we said, was negative for dose escalation and also the cetuximab question, but it did offer us some insight about radiotherapy planning. So we now know that we try to plan these patients using IMRT, and we understand the importance of certain dose constraints such as the lung V20 and the heart V40. And then finally, we talked about that UT Southwestern trial that that looked at accelerated hypofractionation, so 60 gray and 15 fractions, and it did not show superiority in patients with poor performance status, but it is an option for us for patients with very poor performance status that might not tolerate definitive concurrent chemoradiation. In summary, then, we have many options for the management of locally advanced non-small cell lung cancer, and the way that we pursue management for these patients is really going to depend on what the patient looks like and how much they can tolerate, as well as what the disease looks like and what treatments are feasible. So for superior sulcus tumors, remember we talked about a slightly different treatment paradigm where we try to treat with preoperative chemoradiation to a dose of 45 to 50 gray followed by surgery. And if we don't think that these patients are going to get surgery, then we just treat them with definitive chemoradiation and we treat them to a definitive dose of 60 gray. A lot of physicians will try to treat to 60 gray whenever possible, just on the off chance that something changes and even patients that we think are going to be going for surgery up front actually don't end up getting surgery. So practices are very institution dependent. In terms of all of our other non-small cell lung cancers, it's really important for us to determine whether the patient is resectable or unresectable. And remember, this is also an area of contention, and it can be a little bit controversial and subject to debate. The relative contraindications, I think, for resectability are if patients have bulky N2 disease, so mediastinal nodes that are greater than 3 centimeters. If they have multi-station N2 disease, so multiple N2 levels involved, multiple mediastinal levels, or if they have N3 disease, so contralateral mediastinal involvement or supraclavicular nodes. So if patients are deemed resectable up front, we can pursue neoadjuvant chemoimmunotherapy followed by surgery. And then the only indication for postoperative radiation is if they have microscopic or macroscopic residual disease. So if there's an R1 or an R2 resection. But typically when we take these patients for surgery, our goal is to achieve an R0 resection. For patients that are not deemed candidates for surgery, so unresectable, the standard is chemoradiation, 60 gray in 30 fractions, followed by maintenance durvalumab for 1 year, or maintenance osimertinib if they have the appropriate EGFR mutation. I think with lung cancer, there's really a lot of nuance and also a lot of variability from one institution to another. So I think that trying to consider everything together can be very, very complicated, especially when we consider when to give surgery, when to give neoadjuvant chemoimmunotherapy, and things like that. From a radiation standpoint, I think it's fairly simple. When we're treating early stage non-small cell lung cancers, we can just do SBRT. When we're treating more locally advanced node positive non-small cell lung cancers, we can do chemoradiation with concurrent, usually carbotaxol, and then followed by maintenance durvalumab. So our standards, I would say, are fairly simple to remember. What's harder often is committing patients down a particular treatment path. So there's a lot of data in this space, and I certainly have not included every single study I possibly could have, but I've really tried to include some of the most salient studies that I think are important for us, especially for board exams, and just tried to kind of provide an overarching big picture of the management. So I really hope that this was helpful, and I thank you so much for your time and attention.